Hey everybody, this is Rusty, and today we're going to have a lot of fun. We're going to talk about part 1 of 4, management of cardiovascular emergencies. Let's talk about some signs and symptoms. Patient may characterize symptoms not as pain, but other sensations. Those patients may be diabetics or the elderly population. The two most common complaints is difficulty breathing and chest pain itself. Other signs and symptoms may be pain or discomfort in the chest, lightheaded, nausea, vomiting, jaw pain, pain radiating straight through to the back between the shoulder blades, pain in the left arm or numbness, and, of course, like I just said, shortness of breath. Hey, we're not worried about who's your daddy. We're worried about who's your papa. The high-risk can't miss causes of chest pain. There are 3 in your heart: pericarditis, pericardial tamponade, and acute coronary syndrome. There are 2 in your lungs: pulmonary embolism and pneumothorax. And then you think about the hook, the aortic aneurysm or aortic dissection. We think about that hook because most of those occur in the aortic arch. So when you hear somebody say, "I have chest pain," think about who's your papa. Let's talk about ACS, acute coronary syndrome, that progressive narrowing of your coronary arteries, because the arthroma or hard plaque gets caught up in that vessel and causes a little speed bump, which narrows the lumen and slows the blood flow to cardiac muscle downstream. That ischemia or hypoxic heart muscle is a supply versus demand issue. You're shoveling snow, mowing grass, working hard, and your heart's working hard to put oxygen to the body, and you get a little lightheaded, a little dizzy, and chest pain. No, that's a bad thing. But that wonderful plaque comes from nice, juicy cheeseburgers. Oh man, they're so good. Other causes of this ischemia downstream can be vessel spasms, stenosis or hardening of the arteries, and a thrombus. A thrombus, oh yeah. How does that occur? From the inner lining of your vessels, the endothelial tissue gets damaged like little potholes, and then the plaque floats on by and says, "Hey man, I'd like to hang out in this pothole." And then some other plaque hangs out and platelets jump on, and then you've got that arthroma or that speed bump. When that speed bump gets so big that it causes a blockage, it's called the thrombus. Get on the bus, the thrombus. Just like a school bus, when it stops to pick up students, that stop sign moves out to the side. Cars behind it stop, cars in front of it stop, like the thrombus stops the blood flow to the heart muscle downstream. Ischemia or infarct. Ischemia is hypoxic heart tissue. Hypoxic heart tissue. Infarct is dead heart tissue because of that thrombus not letting any blood get past. Acute coronary syndrome is that progressive narrowing of those coronary arteries. The severity depends on the location and the extent of that narrowing from all those juicy cheeseburgers. The picture on the right shows top is a normal artery, nice and fat, and the blood flow is cruising downstream. With angina, you've got some narrowing, and like I said, it's that supply versus demand. You're shoveling snow, mowing grass, heart's working hard, and you start to develop that pain. With stable angina, you can take a rest, pop a nitro, and things will get better. That's angina. Then you have a ST elevated MI, a non-STEMI. Blood flow is getting through, but there is sign of hypoxic heart tissue on ECG, and we'll go over those soon. With a STEMI, an ST elevated MI, there is no blood going through. It could have been from a piece of plaque breaking off and going downstream and lodging and stopping the blood flow. STEMIs, ST elevated MIs, no blood flow downstream. Angina, like I said, it's hypoxic heart tissue, that ischemia, and it's that supply versus demand. Cutting grass, shoveling snow, your heart's working harder, but there's narrowing in the arteries from juicy cheeseburgers. And you start to get short of breath, a little dizzy, and you have chest pain. But you sit down or pop a nitro and it goes away. So stable angina is transient. Pain with exertion relieved by rest or medication. Unstable angina is angina at rest that lasts longer than 20 minutes. New onset angina, you've never had it before, and wham! I've got chest pain. Or crescendo angina. It gets more frequent and lasts longer. And it may not respond to that rest or treatments. This patient needs taken to the hospital. That's stable and unstable angina. Angina assessment. The patient complains of chest pain. They have signs and symptoms of shock, weak, absent peripheral pulses, pale, cool, diaphoretic. It typically comes on sudden and may radiate to that left neck and left arm, or it could just be localized in the chest. The patient often denies chest pain, saying, "Oh man, I've just ate some Taco Bell, I've got some gastritis." The duration of this pain may only last 3 to 5 minutes or up to 15 minutes. Figure out what he was doing when the pain started and what he did, like rest or nitro, once he had it. Remember your primary assessment, that GLT. It's easy as A, B, C. Then you look at these and expose these to set your priority to end that primary survey. Get that general impression, level of consciousness, threats to life, airway, breathing, circulation, disability. Look at those pupils and expose the chest to listen to the lungs and the hearts. Notice the neck. Look at the neck for jugular vein distension. Then see if he has pulses, if he can wiggle and feel his fingers and his toes, all four extremities, and look for pedal edema. Rule out any serious signs and symptoms. That pale, cool, diaphoretic. And then do that initial paramedic care. IV, O2 as needed, and ECG. They have chest pain, so it better be a 12 lead. And then get that past medical history. Sample her OPQRS-TT. You got your signs and symptoms. Review in your mind what you see and what they say. Then get their allergies, their medications, past medical histories, last oral intake, and events leading up to. Then learn their habits. Notice the environment and any risk factors that this patient may have. And then that pain history, onset, provocation, quality, radiation, severity, time, does it come and go or is it constant, and have they done anything to treat themselves? Some field treatments for angina. Like I said, you're going to do your primary paramedic care, IV, O2 is needed, and get a ECG, a 12 lead. Remember, stable angina is pain relieved with rest and nitro. On that 12 lead, you're going to look for ST elevation, ST depression, and T-wave inversion. That ST depression and T-wave inversion is hypoxic heart. ST elevation is infarcted heart muscle. They're not getting any blood flow. You're going to think about your Mona Lisa, Mona Lisa. And MONA stands for morphine, oxygen, nitro, and aspirin. It's not the order you give it in. It's actually reverse. Oxygen if they need it, aspirin, nitro, and if they're still having pain after those nitro, then you're thinking about morphine. And then notify the hospital, transmit that 12 lead, and get the cath team ready. An acute myocardial infarction, AMI, is irreversible heart damage. That thrombosis stopped the road of blood flow distal, and there is dead heart tissue occurring. You'll see that ST elevation and that fireman's hat on ECG. 3 things to diagnose an MI that you need are a clinical history, evidence of ischemic changes on ECG, and elevated cardiac enzymes, troponins, CKs, and MBs. 3 things to diagnose: history, changes on ECG, and enzymes. Let's review the coronary arteries. An MI, location and size depends on the vessel involved. Most infarcts involve the left ventricle. The coronary arteries, right and left, receive their blood during the diastole phase of the cardiac cycle. Remember RIP-SAL. The right coronary artery supplies blood to the right ventricle, inferior wall, and posterior wall of the heart. The left coronary artery supplies blood to the septum, the anterior wall, and the lateral wall. Myocardial infarctions, of course, like I said, can cause ischemia. Heart dysrhythmias are the most common complication, and sudden death is defined as death within 1 hour of onset of symptoms. The goal in any heart attack is pain relief and reperfusion. Let's look at the STEMI versus non-STEMI. The transmural infarct equals our STEMI. The infarcted tissue goes through the full thickness of the heart muscle. When that occurs, you're going to get a pathological Q wave on your ECGs after that patient is fixed. So that Q wave is going to be wider and deeper than a normal Q wave. Pathological Q wave, wider and deeper than a normal Q wave. And then you have your subendocardial infarcts. Those are your hypoxic heart tissues, and those show up on ECG from ST depression and T wave inversion. Looking at this acute myocardial infarction by ECG, you've got your acute coronary syndromes. ST elevation can either be that Q wave MI, deep and wide, or the non-Q wave and be the ST elevation. The non-ST segment elevation can be a non-Q wave, either hypoxic heart, ST depression, or T wave inversion, or angina or unstable angina. And that's what we're looking at on 12-lead ECGs. ST elevation, ST depression, or T wave inversion. And look for that pathological Q wave. Your MI assessment. They're going to complain of shortness of breath, chest pain. Figure it out. There may be discomfort greater than 30 minutes. Get that OPQRST. The onset, makes it better or worse, the quality, sharp, stabbing, crushing, squeezing, elephant sitting on your chest. Does it radiate? Arm, neck, back, or does it localize in the epigastric region? Do your minimum patient assessment, primary assessment, GLT. It's easy as A, B, C. Then you look at these and expose the lungs and the heart so you can listen to lung sounds and heart tones, and look at that neck for JVD. Make sure they have a pulse, wiggle, and feel times 4 extremities, and look for pedal edema. Notice if they have any signs and symptoms of shock. Get your initial paramedic care, IV, O2 as needed, and ECG done quickly, and finish that past medical history and get on the road. That initial paramedic care IV O2 monitor, they're complaining of chest pain, so that monitor needs to be a 12 lead. And notice that ST segment. Is it ST elevation, infarction, ST depression, or T wave inversion, hypoxic heart? Think about that MONA, morphine, oxygen, nitro, and aspirin. Once that 12 lead is obtained, transmit it to the hospital and report it so they can get the cath lab ready. This slide says it all. The leading cause of death in acute coronary syndrome is dysrhythmias, either shockable, VFib or pulseless VTAC, or non-shockable, PEA or asystole. The leading cause of death is dysrhythmias. Hospital treatments they can do are fibrinolysis. It reperfuses all ischemic tissue and much of the injured MI. The door to drug goal is 30 minutes or less. The window lasts up to 6 hours after the onset of symptoms. Some complications with that is bleeding and allergic reactions. And we'll do that fibrinolytic checklist prior to giving it. So door to drug, 30 minutes, and as long as 6 hours afterwards. Door to procedure or reperfusion with PCI and those stents, like a Roto-Rooter, is door to balloon of 90 minutes or less. And then another option is the coronary artery bypass graft, the cabbage. They get a vein from your leg, normally part of the great saphenous vein of your leg, hook it from your aorta to your coronary artery past the blockage area. So there's 3 different types of reperfusion therapies. Other treatments besides reperfusion in the ER on the floor, they're going to do MONA, morphine, oxygen, nitro, and aspirin if it hasn't been taken care of in the field, but you guys are great, so it's taken care of. So think about MONA has big ankles. We're going to thin them out with some heparin. We're going to control some blood pressure with beta blockers. We're going to do some antiplatelet medication with P2Y12 medicines, and that's pretty new, last 3 or 4 years. And then you're going to use some ACE inhibitors for that blood pressure also. And then they're going to be monitoring those cardiac enzymes, those troponins, those creatine kinase or CKs, or creatine phosphokinase, CPKs. And the CKs rise for 4 to 6 hours post-infarct and peak at 24 hours. Then they have the CKBBs, which come from the brain. So CKBB, brain. CKMM come from the muscles. So CKMM is muscle. And CKMB come from the heart. So CKMB, mighty beats. And those are the enzymes they're taking a look at. All right, let's redo the acute coronary syndrome review. 911 dispatch, chest pain. We get on scene, do our minimum patient assessment on everyone, do our basic paramedic care, IV, O2 as needed, and an ECG. That ECG needs to be a 12 lead. We think about MONA, morphine, oxygen, nitro, and aspirin. We transmit that 12 lead to the hospital and notify the cath lab. We do the fibrinolytic checklist so they can have the door to drug in 30 minutes or less. Then they get to the ER, do another evaluation, and hopefully the goal is door to balloon in 90 minutes, or that PCI, 90 minutes or less. And then they send them up to the floor and do that heparin, beta blockers, antiplatelets, ACE inhibitors, and things like that. The circle of acute coronary syndrome care. Wow, I told you that was fun. We are at the end of part 1 of 4. Stay tuned for the next portion. Come on back. See you later.